I'm Karen Feinstein. I welcome everyone. We're so glad you're here. It's a big day for us. This is the launch of the Health Activist Network. One of my favorite lines in history, I'm a history major, Eisenhower was ending his presidency, and young John Kennedy, the newly elected president, came to meet with him at the White House. And President Eisenhower went through a review of all the issues that young Kennedy would have to deal with. And he said, and then there's the CIA. I hand you a legacy of ashes. And I think what Eisenhower was saying is he was incredibly disappointed at the institution that he'd had high hopes for, and an institution that President Eisenhower felt was not serving the nation well. I would not say our health system that we're passing from one generation to another is a legacy of ashes, but I also have to say I think there are very few people in this room, since I know a lot of you, that feel that my generation is passing on to a younger generation a health system that performs as well as it could and invests its resources as wisely as it could. So for many reasons, that's why we're here today. I do think that every generation gets a chance to create the world in which they want to live. Hopefully we have a lot of activists in the room. I know I have lifelong activists sitting across from me. And not only is it a privilege, I think, to be an activist, but it's very rewarding, even though it takes a long time, and there are a number of battles to fight along the way. But we are looking at a time right now where many of you sitting out there, of all ages, have a number of levers to push that I think could be part of our ability to transform a system that is incredibly expensive and has produced a nation where our population health is decidedly disappointing. I think we have a way to use our resources differently. So if you haven't guessed by now, at least 3 of your levers. One, of course, is a new payment system, an alternative payment system with value-based payments. Another is artificial intelligence. Another is technology. And I think I'd have to also add analytics. So there's a very interesting world. The world's going to be transformative. I see some of you sitting here already busy developing the new technologies and the new businesses that are going to help transform it. So the idea is, can we connect all of you? Will you be able to work together? We've been working at healthcare transformation for 20 years. We see some progress. We see a lot more progress that's possible. We brought our interest in taking the many people who've been through our fellowships. I see a lot of alumni here. There are about 900 of you. Forming a network with you as the core, but of course going way beyond that. I also see people in the room who've been health reformers all their lives. And could you, by networking, create the kind of change, momentum toward the health system we'd all most like to have? And we brought it to the DSF Foundation, and Nick Beldicos, we're delighted he's here, and he believed in the concept enough to help fund, in partnership with others, the Health Activist Network. So we're very excited today to be kicking this off. There are power in numbers, and I do believe that we're going to hear from one of the best health activists that I know. I probably could say the best health activist that I know in the country, someone who's been a great inspiration to me, and that's Rob Restuccia. I don't even know how long ago I met Rob, but I came from, I have to be honest, the children of the 60s and 70s, and our idea of social activism was confrontation. And we're pretty good at it. You know, we marched and we picketed and we got really angry. Rob knocks me over. He's had a lifetime of activism. I never see you get angry. And we're going to ask you about that. And you never get discouraged. You never get angry. We never see it. You just keep going. So we have Rob here to kick off our first meeting, and I can't think of anyone better. At the moment, he's executive director of Community Catalyst, which is a national nonprofit organization that was formed in 1998 to help build state-level advocacy networks and consumer leadership to improve health and healthcare. Rob's built Community Catalyst into one of the most respected consumer advocacy organizations in the country, and they do all kinds of things. I've known them from expanding children's health coverage to working on a lot of consumer-directed activities, such as conflicts of interest created by the pharmaceutical company, protecting consumer interests vis-a-vis hospitals and insurers, strengthening hospitals in their community benefit obligation, and I know for many of us in the room, protecting Medicaid from cuts and being steered in the wrong direction. I actually knew Rob best as the founder and executive director of Healthcare for All in Massachusetts. We used Healthcare for All as a model in bringing the Consumer Health Coalition here to Pittsburgh. Rob has a bachelor's degree from Harvard, a master's degree in public administration from the Kennedy School at Harvard, and serves as an adjunct professor at Boston University School of Public Health. So we are delighted. This is not the first time I have welcomed Rob to Pittsburgh, and I am quite serious when I say he's been, for me, a model. So, Rob, you have very impressive credentials. You could have done anything you wanted. Why did you decide to become a health activist for your professional life?
Well, let me just start and say how thankful I am to be here in the leadership. The foundation and Pittsburgh has been really a model for a lot of us in terms of looking at health reform. I started out as an activist probably in high school. I think working for the first anti-war candidate, actually at Waltham, Massachusetts.
I know it well.
And I thought about issues related to social justice. But coming out of college, I decided to go to work in a hospital to think about going to medical school. And I worked as an orderly in the surgical unit of Santa Clara Valley Medical Center in San Jose. At the time, there was no air conditioning. San Jose is hot in the summer. Mainly saw uninsured populations. So I saw the contradiction between what this country aspires to be and what was happening to people. So I became very involved in the United Farm Workers. Became an organizer for the United Farm Workers. In terms of the health piece of that, it was really seeing the sort of disparities in healthcare that low-income people of color had, and then translating it into action in terms of the work I was doing in terms of unions and other things like that.
So tell me your secret. I have never seen you give a talk, come to a meeting. You never seem angry or impatient. How do you hide it?
Should talk to my kids. I approach advocacy scientifically. And I think there's a lot of different roles that are really important for advocacy. And I think it's important that there are people who are angry out there and torchbearers for an ideal solution. There's a lot of people out there who talk about single-payer healthcare, and I think a lot of us would think single-payer is the best. For me to be effective in thinking about this, is really to bring people together and try to build the best in people. And within institutions, even the worst institutions in terms of their policies, there's always good people, and trying to figure out how to do that. And I think treating people respectfully in that way, I think, thinking that, if you build on the best, you can make some change. And that's been sort of the history of my advocacy, has been able to build coalitions to really work with people across the board. Very rarely will I do, I have control of my emotions enough to know that it's probably generally not useful. Occasionally it's useful to get angry. In the negotiations, I can get angry. But I think for the role I play, it's best not to be angry.
Well, one advantage you have at Community Catalyst, you get to look around the country. You get to see a lot of advocacy groups. You get to deal with people working on a wide variety of issues. As you look at all of this, could you single out for us some group somewhere who took on an issue and they were wildly successful? Something we could maybe learn from.
Well, I think there's a lot of examples of that. I think about in Ohio, back in, this is probably over 20 years ago now, or close to 20 years ago, the Blue Cross Blue Shield corporation decided it was going to become a for-profit entity. And this it followed California Blue Cross converting and a bunch of others. And the advocates in Ohio came together, organized, and stopped that from happening. Even though that everybody at that point in time thought it was inevitable. In looking in California, the advocates in California started out challenging Blue Cross Blue Shield in its conversion to a for-profit status. And the way a conversion works is that when you move from nonprofit to for-profit status, there's a community benefit. So you either create a foundation or give something back to the community. In California, and this was 1995, the Blue Cross Corporation thought that they would be able to create a foundation of $300 million and keep control of that foundation by appointing corporation members.
I remember this.
Remember this?
Quite well.
So Consumers Union, at the time Community Catalyst wasn't in existence, but our predecessor helped intervene, organize the community, organize the Attorney General. So what ended up happening is 3 foundations were created with a total level of assets at $3 billion, and it was totally independent of Blue Cross Blue Shield. So, that type of thing, which, frankly, often goes under the radar screen in healthcare. You see these deals being made, and, unless there is an active consumer advocacy, activist orientation, the wool can be pull over your eyes.
Why do you think, we probably all have our own theories, but the consumers vis-a-vis healthcare are on the whole very passive. If something goes wrong, they think it was a random mistake. If their bill is so opaque, they can't figure out what's in the bill and why. When bizarre things happen, they just assume, well, that's what happens in healthcare. Why is the healthcare consumer unusually passive?
Well, I think it's a very diffuse interest group. There's a lot of special interests that are very powerful. I mean, I think back to really how I got into health advocacy. I was working as director of the House Officers Association at Boston City Hospital, and I was a director of interns and it was a union of interns and residents, and the interns and residents would come to my office. They would sit in this chair. Actually, Ken Thompson and I were just talking about the office was this, turn of the century building, the previous century, and we would just talk about what was going on, and the House officer would talk about, they say like, geez, we just got this patient from the Mass General. And there was a note, attached to their chart saying, uninsured can't be treated here. Then I can remember this person coming from New England Medical Center and the same thing. And it sort of like this pattern was occurring. And so we started to do an investigation, and the House officers and some of the nurses started thinking about, okay, why is this happening? And it turned out that legislation had passed in the Massachusetts legislature changing the hospital reimbursement law. And it gave an incentive for private hospitals to dump to what was the public hospital at the time, Boston City Hospital. So consumers had no idea that it was happening, and that actually led me to help start Healthcare for All. So I think for what you're trying to do here is so important. The connection of health professionals to consumers is a critical piece. Because for consumers, the health system is a black box. You really don't know what's happening behind the scenes. And that's where I feel like at Community Catalyst and all the organizations we work with, it's really critical to bring progressive health professionals together with consumer advocates.
And I'd love to say, for the consumer, it's a black box, but for those of us sitting in the room, we can see it pretty clearly, but it's a black box for a lot of us.
No, I think part of the struggle is how to make it more opaque. I think that's sort of the way the special interests operate, and to challenge that. To look at sort of opening up, putting light into it. I mean, that's, the work that we did in the pharmaceutical industry was really to try to, expose the kind of relationships that pharmaceutical companies have to physicians. And, I think we've made some progress on that, in terms of like the insurance industry and pre-existing condition exclusions. Of course, we have a legislation now that would just roll that back. So the struggle is a constant one.
So and we have some staff here, they're probably tired of hearing me say it, but when I look for inspiration, when I look around the country, maybe the world, for health reformers who are inspiring, I look at you and I look at Michael Jacobson from Center for Science and the Public Interest. To whom do you look? Who are your models of people who are really successful, thoughtful, fact-driven activists?
Well, I think my inspiration, Martin Luther King remains the person that I think about as the most inspiring leader. I think in terms of health activists today, Cindy Mann, who ran Medicaid. Cindy came to Boston as a legal services attorney and knew nothing about healthcare. She was sort of tutored by some of my staff at Healthcare for All, and I think she led the Obama administration's expansion of Medicaid. So there's, I think, a lot of unsung hero. Don Berwick, I feel like, has really changed the paradigm in terms of how we think about health quality and healthcare costs. I think in the public health arena, there's some just amazing public health leaders across the country that really have set us in a very different direction, looking at social determinants of health in a very different way, connecting health to health care more. So I'm inspired by lots of different people. I feel like, there's a lot of people who have made huge contributions.
When I go to global health conferences, particularly when it's a conference that's organized with a lot of people from developing countries, and you meet the network of physicians who are working, particularly with HIV/AIDS, but other conditions, antibiotic resistant pneumonias and other conditions. I'm astonished by how accepting they are, supportive, how much they do to develop people without professional degrees to be part of the health team, to be their eyes and ears. If you say to a doctor in Cape Town or Rwanda, how important are your community health workers, they'll say to you, are you kidding me? We couldn't do our job without them. It seems to me we've been more resistant in this country. Do you see a change in that?
There's definitely a change, but idea of professionalism and the idea of sort of keeping everyone within their own box continues to be a strong sentiment. I mean, we're working on a dental therapist program that's based on a model coming out of the native populations in Alaska, which is very successful, 2-year training dental therapist. The kind of resistance from the dental association is amazing. If something makes me angry, is how the dentists have reacted to that.
I think we have some people in the audience who feel the way you do.
It really is immoral. The kind of, to say that people have access to health care, access to dentistry, and to say that they're serving these populations, it's just wrong. It's just wrong.
It's a huge problem here in Western Pennsylvania. We have a serious shortage of dentists, and we've tried to get advanced practice dental hygienist certified licensed.
Right.
It's a battle.
Yeah.
And yet, interestingly enough, we have quite a few of our dentists who don't want to serve the population that the advanced practice dental hygienist would serve. So it's
Well, join us in the struggle. We would love to have another state sort of move forward on it. Working hard on it.
And you're great about not getting discouraged. Do you ever feel that take the public health sector and our schools of public health, many of whom have graduates here, are there ways that activism could be taught, promoted, built into the curriculum? We know when we were doing our early days of activism around medical error, we couldn't get the public health community, not CDC, interestingly. I'm talking about the local schools and the local practitioners. People said, well, medical error is really not a public health problem. And the kind of activism that we were engaging in seemed not comfortable. And I'm wondering, maybe you see more of it in Massachusetts, but could the schools be doing more to encourage their grads?
Well, I actually was recruited to teach at the Boston University School of Public Health about almost 20 years ago now, specifically because they had no course on that. So I think there is a growing sense that, frankly, public health is not the strongest advocacy profession, and that they need to think about it. I think that we need to I think there's an opportunity now, because the movement to social determinants of health makes public health more relevant to the health care system. But I think we have a long way to go. I'm amazed sometimes at how naive the public health community is around social change. I think there are a number of public health commissioners, and actually Karen Hacker's an old friend here, who have been very strategic. And I think about John Arbach, who was at CDC and just now is at the Trust for America's Health. Amazing job in Boston. Around tobacco control, needle exchange, a lot of different things. But to take it out of the local and put it into the state and federal is another set of skills and tasks that need to happen.
And if you were changing medical education?
That wasn't on the list of questions.
That just came out of left field suddenly. Like, why blame public health if I'm not going to talk to them about this?
Well, I think some of it is to change the incentives in the system. We certainly undervalue certain things like primary care and behavioral health. I think there is a shift in terms of how medical schools are operating, and I think one of the things that was an innovation is to have medical schools be much more associated with health centers and and starting from the bottom as opposed to the top. I think that the challenge, and I think physicians are not taught to be team players. And I think a lot of the work that we have done is sort of like to try to create teams and to try to, as you talked about community health workers, I mean, they're a critical piece of any health system that's going to be responsive to the needs of disadvantaged low-income communities. We actually have John McDonough, who was my successor at Healthcare for All, is teaching at the Harvard School of Public Health, and we've been working with him and a physician, Bob Master, who is sort of the master of team building and dealing with high-risk populations, to really start a curriculum at the School of Public Health for not actually directed to executives of health plans and hospitals, not at physicians. So the idea would be to create sort of a movement around more team-based care. Something like what Jeff Brenner's doing in Camden.
Yeah, right, exactly.
That's the type of thing that we really need to move towards. And that's sort of a model of care that's just going to be much more responsive to the needs of the population in this country that have historically been underserved.
Well, and my last question before I throw it open to the audience, I gave you some of my levers, at least what I have in mind as levers. We're talking to a lot of people here, would like to, I think, be active. What levers do you see out there to push? Like, if you could change X, a lot of things would change. And mostly when I think of change, I mean, we get a much healthier population for the resources we've invested.
I think change insurance companies and how they operate, and change medical school, change academic medical centers. I mean, academic medical centers are totally siloed, and they do not respond to the needs of the patients. They're really set up for the needs of physicians and others there. And, it's a bad paradigm. And I think we need to sort of move much more to sort of a whole team-based approach. I think the insurance system just sets up the kind of dynamic, and where it looks like we may possibly go back to where they're just looking at managing risk as opposed to managing care. And I think we have to shift in a new direction.
Well, I'm going to open it up to people in the audience who would have a question. Oh, I see Jay.
So in a broader context, right, we all know Thomas Friedman said the world is flat, and the Nobel Prize winner Muhammad Yunus said maybe it's flat, but it's perhaps more bumpy. And the UK Foundation for Income Equity Gaps basically did this study where they basically found that if you look at any problem in the world, whether it's education, whether it is behavioral health, whether it's lack of health care, it is the gap in the income equity which defines it, which we may comfortably define as social determinants of health.
Right.
But is it really that when we're looking at activists who are looking at the income equity gap as the foundation of alleviating the imbalance of all forms of what I would call malice in the world today?
We're getting busy to try and fix the income gap. I sort of said to the staff this morning, we should do something about the inequality of income. No, it's a challenge.
Yeah, I mean, I think that's right. I think, one of the things we have to do is address the income gap. If you think about the Affordable Care Act and you look at what they're trying to do, essentially they're taking money that's paying for health coverage for the lowest income people in the country and giving it to the highest income people. I think you can't just think about health care And you got to think about health, and income as part of that. So, my organization, I'm on the board of another organization that's looking at a millionaire's tax in Massachusetts. So, there's a lot of things we have to do. But I do think the inequity in healthcare is so palpable that you have to do something about that. You have to address that. And the kind of disparities, I feel like we've made important strides in addressing, the issue of the imbalance between what someone who is upper middle class gets in healthcare and someone low income gets. So I think, I don't disagree, fighting that fight too.
When you go in the hospital, though, it is I hate to say it, but it's an equal opportunity medical error field. And even the hospital experience, you can be at the highest income bracket, you can be mayor of the city, and you can get a hospital-acquired infection and die.
Hi. So my only mentor, I would say, in medical school was Bob Masters, who introduced me to the community health centers around Boston City Hospital. My experience as a medical student arriving at that system was that there was Boston City Hospital, and across the street was, I don't know what it was called then, University Hospital. And there were like rich people in here and poor people in there. And I was like, what is going on here? And it just struck me. I had kind of lived in that system my whole life, but it hadn't struck me so deliberately. Now, at the beginning, you said there were 3 things to focus on and what's the future of healthcare is. I run a community health center now in FQHC, and all I see is that is so complex. The people's actually needs are both simple and complex, but they're really simple. There's someone to sit in a room, talk to them, hear them, control their blood pressure and diabetes, which seems complicated, but instead of having all this complicated research and the patient-centered medical home checking off boxes, things are really actually at the basis of it fairly simple. And if we take those simple things and apply them to a lot of people, like vaccines, that actually is what keeps people living long, right? It's not, the research has to continue. That's why people live with HIV, and that's why there's going to be a cure for Ebola or prevention of Ebola. Those things have to continue. I'm not an anti-research person. But medical care, sitting here face to face with patients every day that we see 60% of our patients are refugees who think what we give is just amazing, right? But I think that it is possible to do that. You just have to break it down to the simplest thing. And maybe it's because I'm a geriatrician, that's what it is, team-based, taking care of the whole person. It's not that complicated, and I think we just get more and more complicated into this stuff. It's really simple to bring to the most people.
And I think rewarding, Andrea Fox is a geriatrician. Someone told me just yesterday that they did a study of all the medical professions, the specialties, and they asked which the specialties, would you choose that specialty again? Number 1 were the geriatricians. I see 2 geriatricians sitting next to each other. And so I said, that's very interesting because we all know this. Geriatricians don't get super rich. So I said, well, explain it. And they said, well, geriatricians like building a relationship with their patients. They like it. They go into geriatrics because they know many of their patients are going to be complicated. They're going to need more than, I came in, do I have a strep throat or don't I? Thanks, going home. And I thought it was very beautiful. But it is interesting also, Andrea, I don't know how much medical schools build that into their training, that, the joy of having a relationship, of the simple act of talking and listening and working through problems. But I think it's sad that this is the happiest of all the specialties. And it'd be nice to understand what the DNA is, because as you know, we have a serious problem with demoralization right now in the medical field, and a very sad problem nationally with physicians who end their lives. It's very tragic. We would like to make sure that whatever is giving geriatricians so much satisfaction, we could capture and spread throughout the professions, these specialties. Any other? Yes.
You described the system at large as a black box, and I was thinking about how big that box is and how complex it is and how there are boxes within boxes. What has been your strategy to decide which part of that box to study, and within that area, what to pinpoint to have the maximum effect, what kind of the weakest point is to making a really large change?
Great question.
It's a really good question. So I try to think about this systematically, and there is a model that a professor from Michigan came up with, the John Kingdon's agenda-setting model, and he talks about 3 streams, and when the 3 streams come together, the political problem and policy stream, there's a window of opportunity. And to really think about that, part of it is listening to people as to what is the problem. I mean, when I was at the House Officers Association, it was pretty clear one of the problems was that uninsured people weren't getting the care they needed, and there were 600,000 uninsured people in Massachusetts at that point, so we needed a solution to that. So I think one of the things that advocates need to be is just, realistic in assessing the environment, don't get fooled by your own beliefs. Test out your propositions. And then, thinking about sort of how do you, what would it take? Do a power analysis. What would it take to move something? So, when I was at Healthcare for All in Massachusetts, one of the things that we thought about, we saw was that the teaching hospitals weren't providing community benefits at the time to health centers. The health centers were starving, and the teaching hospitals were building and building. So we figured out, if we challenged their tax exemption and started going to the Attorney General and thinking about how to build a coalition of community organizations, and that eventually led to the Attorney General, moving on community benefit guidelines. So, I think thinking strategically about it and realistically, I say organizing and advocacy is scientific. It's not, there's an emotion to it. You need to put your passion in it. You need to be mission driven, but you need to really think about it, in the same way you would think about solving any problem.
All right, thank you. I'm Ken Thompson, and I just wanted to just comment. In the early 80s, I don't know if you remember this, Rob, there was a study that came out about the death zones in Boston.
Yeah.
And you spoke very eloquently about the way that the House staff sort of alerted you to what was happening around the hospital systems. The death zones in Boston basically found that there were areas of Boston, which interestingly were clustered around the 3 medical schools, where the rate of premature mortality was much higher than the rest of the city. And originally the thought was that was because maybe they were getting bad medical care, but actually the real issue is it's where all the poor people were living, which is why in the old days, why the hospitals were sited there. So that was about health professionals getting tuned into what was happening because they were experiencing stuff and starting to amass data and starting to think about it. You also made the point earlier that around advocacy, the connection between progressive health professionals and consumers is kind of the secret ingredient here in that work. So I'm wondering if maybe you could give us some hints as to how to make that connection between health professionals and consumers so that we can actually move an agenda here that would be a little bit more forceful and would build both of those entities up a little bit.
Yeah. Maybe this is, hopefully the start of it. I think in some places, I think it's driven by the health professionals. In some places, it's driven by the consumers, and it depends on sort of like, what kind of resources, what kind of organizations exist. I mean, in my office right now, we have a group of, we call them the baby docs. They're at the various schools of public health, and they're taking their third year or whatever it is. They're studying public health, and they got engaged in sort of thinking about, what's happening in Congress, and they've tried to coalesce in terms of a organization, and we're connecting them to the state consumer advocates across the country. To some extent, I think within the medical schools, they need to have mentors to push them out to the community. Because in Boston, there were those mentors. You had people at the Boston University Medical School pushing, open to sort of getting the house staff out there. So I think some of it is consumers. For consumers, sometimes they close themselves off and think they can do it by themselves. The consumer organizations think they can just deal with it just by organizing consumers. And, the power dynamics in this country are such that, particularly a disenfranchised group of consumers are going to have a hard time doing it. So.
Okay, next question. This is very specific about medical errors. The subject's come up a little bit. And that is that when patients are considering having a procedure, and they might be talking to 2 or 3 different doctors, and I think it would be really helpful if their doctor was required to make available their past history of complications in performing procedures of that general type. How many patient errors they had, say, of some serious complication, so that the patient can sort of compare A, B, and C and decide which way they want to go, rather than just kind of a vague song and dance, which is often what you get from a surgeon, in my experience.
Well, I think we'd be, I don't know the specifics around that. I think in general, we sort of feel like transparency is important. To the extent that we're asking consumers to make rational choices, how can you make rational choices without information? And it's like part of it is the guilt mentality of, they want to hide it. I mean, I spent a lot of time, and I think there's been some significant progress in Massachusetts, the medical society not wanting to expose the records of physicians. And I think you have to do it fairly. You have to really understand who their patients are. We're big supporters of risk adjustment and understanding that. But I think the point is, we're supposedly moving to a consumer-driven healthcare system. Well, how can you be a consumer without information? Consumer reports.
The health plans claim that they actually would like to do this. They would like a couple things. One, it's the physicians aren't enthusiastic. But the other is, I think it would help if they heard from a lot of their customers that they want this. Maybe it would give them some backup. But this conversation is very interesting, and obviously we should have access to that. When you buy a toaster, when you go buy shampoo, you get all kinds of information. I think that it's something, if enough noise was made from the consumer, I think some of the plans would respond. At least it's worth a try. It's a good suggestion.
I would like to make a quick comment regarding medical school education, and then I'll ask my question afterwards. So I'll say that.
Spoken as a medical student?
I'm a fourth-year medical student. So I would like to say that within the last 2 to 3 years, I've actually noticed that there are some conversations that we started to have in our environment that I feel like I didn't hear of them, say in 2012 when I started, when I first enrolled. So we talk about quality improvement, we talk about patient safety, we talk about cost-conscious prescribing, we talk about policy and advocacy, and in fact, we have student groups who are gathering together and working actively on those issues. So I think we're being heard. We've made some progress there, And I think I was very happy to realize that. Now, in terms of understanding, one of the most frustrating things for the consumer is, I think we kind of touched on it earlier, is about transparency. And one thing that's pretty much dear to my heart is, cost of healthcare as well. And I think not having the data, I referred to some of the CMS analysis in the past few years, and based on their perspective, they were saying that the strongest drivers of healthcare cost were, so top three were medical imaging, so that was one. Second thing would be the pharmaceutical company, as well as medical devices. And then the third thing was pretty much administrative healthcare overhead sort of payment. Now, being an activist, just wondering how much of a leverage, what would be the strategy that you would kind of recommend to us if we wanted to kind of influence the way that we can redirect or pretty much redefine what are these drivers of healthcare cost in a more societal perspective, friendly way.
Well, I think there are different answers to each of those issues, and to some extent, I think the whole issue of healthcare costs, we need to change the paradigm of the system, and working on thinking about getting a system that is more efficient overall. I mean, for example, pharmaceutical costs. We had a project where we sued drug companies, which we would say for lying, stealing, and cheating. I say that very calmly. No anger in my voice.
You're a model, though.
And that, we thought we could actually, when part of this was sort of the slowness of generics coming to market and how the pharmaceutical companies were colluding and suing people around that basis. That actually worked somewhat effectively for a little bit, but I think we're going to need some legislation for that. And right now, it's hard to do on a state level. It's almost impossible to do it at a local level, so we need national legislation. So it would require changing who's in Congress and changing the president, because I don't think President Trump is ready to address that issue. I think one of the things we did that was probably one of our most creative things, Bob Master, who Andrea mentioned, is a sort of the guru of caring for special populations. So we actually created a nonprofit health plan with him to try to organize care more as a team-based care, and to see if that could really address some of the quality and cost issues. And I think the question of whether it's addressed the cost issues is sort of to be determined. I think it's addressed the quality issue. One of the things I think you see in dealing with a lot of low-income populations is that there's so many other issues they're dealing with. In order to get someone healthy, you have to deal with the fact that they live in a apartment that is not habitable by anybody human or theoretically, and they're not getting sufficient food and all of that. So I think there's you listed a number of different problems. I think you're sort of thinking about each of those somewhat, and I think thinking about candidates. I mean, Don Berwick ran for governor of Massachusetts, and he ran on a healthcare quality and cost agenda. And I think had he won, we would have been sort of moving much more on that agenda. So part of what I would suggest is really thinking about sort of that from a public policy standpoint.
Well, Well, one more question. Robert, I have to just say I have to keep everyone on time. He is accustomed to having things on time, and I'm trying, Robert. This is our last question.
I work for a nonprofit in Pittsburgh, primarily human services, health, housing, et cetera. And I chair an advocacy committee within our organization. And we've talked a lot, here and other places about how we as professionals can, help to advocate for change. And one thing I keep hearing a lot tonight is that we have to get the consumers to say something as well. And so I guess the problem that I continue to come back to and that I never really find an answer to, I'm hoping you can help shed some light on, is how do we convince people or help people that are consistently disenfranchised to see that their voice matters, to convince them that yes, this is going to make a difference, because I think collectively it will, but doing that one at a time can be really, really hard.
It's really a critical question. We had Celinda Lake, who is a sort of very well-known pollster, came to my office and we had an event 2 days after the election, and she had done some polling. And she was talking about repeal of the Affordable Care Act, and she said, part of the problem is the people who were helped by Obamacare in large numbers didn't vote. Then, there was actually a large number of them who voted for Trump. I happened to be I was invited to the White House when Sarah Cliff was interviewing Obama, and I sat next to the woman. I know Sarah Cliff writes for Vox, and she wrote sort of a famous series of articles about this one woman who had signed up 1,000 people for Obamacare. She had Obamacare. Her husband was in the hospital, covered by Obamacare, and she voted for Trump. The president had invited her to ask a question. I think we have to really do a better job of fully enfranchising consumers, and I actually think it has to happen at the community level, not the individual level. We need to get community organizations to really help people understand the importance of participation. We talk about consumer engagement in 3 stages. Consumer engagement in terms of your relationship to your provider, consumer engagement in relationship to your plan or whatever, and consumer engagement in relationship to sort of society and civic. So, we just have to do a better job. I'm not sure there's a simple answer except organizing at a community level and really engaging people. We are not going to change things unless that happens. And, I think about, I've been doing this for a long time, and I think about everything I've done. Most of it is being threatened right now, could be overturned in the House, at least legislation in the House tomorrow. It is sobering, and then think about all the people who are helped by this, who are sort of sitting in the sidelines. I mean, we just have to do something different. And I'm old enough to know that I'm not the person sort of to know how to address some of the newer approaches to sort of organizing. I don't do Facebook very much, whatever, and that sort of stuff. So I think, that's incumbent on those of you who are in that generation where it's, to think about, okay, what's the next generation of, the civil rights movement, the anti-war movement. Invisible is doing a great job. Move On's back on doing a great job, but, we need to do that. And, we need to do it together because, my organization, which we have a lot of young people who do that, we're trying to build that sort of connection across the various approaches. Because I always think one-to-one contact is just a critical piece of success. So.
And I do think as an answer, we've got to get accurate information out there. I was driving over here today, and I heard about the new legislation, whatever, that is going to reopen coal mines. That's really the answer. So those of you who've ever seen the Matiki mines, huge coal mine operation in southern Garrett County on the edge of West Virginia, you know how big the parking lot is? There's no parking lot, because that coal is coming out of the ground and it is moving down long chutes, and there are not people moving it. It's mechanized. Do you know how many community health workers Rwanda has? 48,000. And they all have iPhones. And they collect information and they receive information, and frankly, they do a better job getting people on their antiretrovirals than we do in this country. So I'm not being funny, but forget legislation about coal. You should have legislation about community health workers if you want to create jobs among the people who live in our part of the world. So I think we've got to make sure we keep the information flowing, accurate information. I am concerned, coming from hopefully reliable sources. I thank you all for coming. I want to thank Rob very much for coming back to Pittsburgh. We can give him an honorary Pittsburgh pass. And I want to thank all of you for showing an interest in something that is very dear to our hearts. I have to thank Nick and the DSF Charitable Foundation for believing that we could actually have enough activists here in Pittsburgh to start a core for what hopefully will just keep spreading and spreading beyond our borders.